So it's a timely moment for us to talk about antimicrobial resistance. And remember, in the beginning, we asked ourselves, so antimicrobials, antibiotics, are they the same thing, same what's up, or is there a difference? The person who understands those things very well is a senior lecturer at the Department of Medicine at the University of Nairobi, and an infectious diseases specialist is our guest today, Dr. Loice Ombajo. Good morning.
Good morning.
Karibu sana.
Thank you so much. Thanks for having me.
You are going to educate us and be kind with us. You know, be kind with us. Mambo ya dawa, unajua kunywanga dawa tukiwa wagonjwa. Tukipona, hakuna haja kunywa dawa. But you'll tell us about that. First, Jano is going to welcome you with the day's quotes.
Absolutely. Achille Mbembe once said, power... Achille Mbembe
You keep telling it. It's not a common name. It's not like Ali Mazrui.
Yeah. But Sasa is from Achille Mbembe. Yes, he's from Cameroon. He's a philosopher and political theorist.
Okay.
And he once said, power is never just what is done. It is also what is allowed. Right? I'll say that again. Power is never just what is done. It is also what is allowed. What comes to mind when you hear that, Dr.
Wow. So I'm going to put this in the context of antibiotics. So I think we've allowed ourselves to use a lot of antibiotics. We're meant to be regulating antibiotic use. And I think we're just talking to someone earlier and saying, I went to another country where they regulate antibiotic use, and I went to the pharmacy and I wanted to buy antibiotics. And I said, but I'm an infectious disease specialist. I said, you have to go to the hospital and come back with a prescription. So I think we've allowed ourselves to go down a rabbit hole of using antibiotics as we want it to be used or as we want to use it. And it's not just that we want to do it. The system has allowed us to do it. I hope I interpreted Ashembe.
It's what is allowed, because it's after a while it's what almost becomes mainstay. Yes, because power. So it's concerned. We've all talked about this. Even the doctor at the beginning, when you were saying, we just measure against the older child and then give him a dose, and she was just like, oh my Lord. So I'm sure you deal with this a lot. But I mean, maybe just start people off with just giving us an understanding of antimicrobial, antibiotic, just those definitions.
Okay, so if you think about back to biology, a microbe is a small organism that can cause infection. So here could be a bacteria or a virus or a fungus or a parasite, could be malaria, So those are microbes. So anti is something against a microbe, so antimicrobial. Antibiotic is just one of the antimicrobials that acts against bacteria. So that's where we start from. You also have antivirals that we use to treat viruses like the flu or HIV, or those are antivirals. We have antifungals, like if someone has a ringworm, and they're given an antifungal cream. We have anti-parasitic drugs like anti-malarials, because malaria is what we call a protozoa. So, and we have other protozoa like amoeba, so you have anti-amoebic agents. So all those are antimicrobials. The biggest concern we have is actually antibiotics, because that's the one that everybody seems to know. But there are other concerns like anti-TB medications or anti-malarials, anti-HIV medications, because all those are groups of drugs to which resistance can develop. And when we talk about antimicrobial resistance, it means that this microbe, be it a bacteria or a virus, has sort of changed its characteristics so that the drug that's meant to be working against it can't work anymore. So it's almost like if you think of, let's say, bacteria, a drug binds to it and inhibits its growth or kills it. So if it changes that binding site, or if it breaks down that drug, then you have antibiotic resistance. You'll give the antibiotic, but it's not working against the bacteria.
What will make it be resistant? Because I'm imagining that scientists have sat and studied this microbe and known the weaknesses and come up with something that will just work on those weaknesses properly. So at what point is this microbe resisting this weakness and being clever enough suddenly? Very clever.
So it's not only humans who are clever. Every organism has to be clever. That's how they survive all the changes. They have survived weather, they survive toxins, they survive everything, and they continue to thrive. So with every organism, if you subject it to some toxicity, be it in this case the drug, then it has to think about survival. And the fit ones will survive because they change and evolve in order to survive in the presence of this antibiotic. So that happens even with a virus that probably has no brain. No, maybe they have brains. That's why they survive. They're all clever, and they change in order to survive. And that happens with every species of living things in the world.
Okay.
It's evolution at a microscopic level.
Exactly.
Microscopic.
Yeah. Okay.
So then it's a given that at every juncture it's fighting for survival. So it's fighting to learn this thing that has been brought to kill it.
Yes. So if you develop a new antibiotic today, this bacteria has never been exposed to this antibiotic.
Instantly.
It will kill it. But a few will survive it. And over time, it learns it so that within a year or so of using the same antibiotic or whatever duration of time, it's suddenly not working, So that's a problem we sort of had. Initially, penicillin was like the first antibiotic developed, and it revolutionized treatment. Everyone was now getting better. Then penicillin now, most things will not respond to penicillin. So we're beginning to think of sort of what we call broader antibiotics that can still work. But this bacteria is still evolving every time. So every new antibiotic you develop, after a short while, resistance will develop.
Okay. Yeah. So the ones that will survive will survive. Walk us through why it's problematic to self-prescribe medications, and antibiotics are the ones we know, but you've also talked about TB medication, HIV, why it's problematic to self-prescribe those and not also finishing a dose.
So let's start with self-prescribing. So let's say you have a running nose, you wake up with maybe some sore throat, or there's this mild cough that, or it's coming because your child has come home with it, The usual Kenyan response is to go to the pharmacy and look for something. And there's something that most people know. I think every Kenyan knows this antibiotic. It doesn't matter which village you go to. It's called azithromycin. Everybody says, I bought some azithromycin. I took it for 3 days or whatever time. But the human body has a lot of bacteria in it. And this bacteria is actually good for us. We have a lot of bacteria in our skin. We have a lot of bacteria in our gut. We probably have more bacteria in our gut than the human cells we have in our body. This bacteria help with things like digestion. And where you remove all the bacteria, other organisms will come to replace the bacteria. So the bacteria is actually good for the body. But you keep exposing this normal, friendly, hanging around you with, no ill intention. Right. You expose it to antibiotics. What happens is some of it becomes resistant. So you have bacteria in your gut that has resistance to antibiotics. And usually when you get an infection, unfortunately, it's what is within you that infects you. So if you're infected with, normal bacteria that's not resistant, we can treat you. But the minute you've been taking a lot of antibiotics and you end up with resistant bacteria, it means the day you get a urinary tract infection, you get a pneumonia, then you have bacteria that's not responding to antibiotics because it's become resistant. So that's a danger of self-prescribing. And a lot of studies have actually shown that if someone takes antibiotics for, let's say you took antibiotics a month ago, you have resistant bacteria. But even if you took it a year ago, chances are you may have some resistant bacteria. So there's no healthy number of times that you should take antibiotics. Some will say, I only take 3 times a year. Or 4 times a year. There's no healthy number of times. And it's a balance. If you don't have an infection, don't take it. If you have an infection, then antibiotics are good because they will treat that bacterial infection. The common thing, the common cold, are caused by viruses. And remember we talked about all those antimicrobials. Antibiotics treat bacteria. It doesn't matter if you hit a virus with a sack of antibiotics. It will not treat the virus. It will not change its characteristics to suddenly treat a virus.
Okay, so
the other thing is the doc is telling us about self-prescribing, where we go and we self-prescribe. There's the other side, where physicians overprescribe antibiotics. Sometimes you see that. You go to a hospital kwanza with a sick child, you know you'll definitely come out with a sack of medication. So you pain, and this is an antibiotic.
Yeah.
Especially antibiotics. Yeah? Does that happen a lot? I mean, physicians also just doing the same thing. Everything, patient comes, antibiotic prescription.
That, unfortunately, is true. And I think hospitals and healthcare workers are as responsible for promoting resistance as are people who are self-prescribing. And the scenario you've described is very common. So 2 things. One, people feel that I'll go to a hospital, I'll take the whole day, I'll get a bunch of tests, and all I went to was a flu, or a cold. So people will avoid hospital and prescribe for themselves. But on the flip side, a mother comes, and mothers are notorious for this. They come with a sick child, and they want something to be done because they want to sleep tonight.
Yes.
They didn't sleep last night. And a sick child is distressing to anyone. So they also demand antibiotics. And they say, last time my child came, alidungwa ile ceftriaxone. That's a common antibiotic that even mothers have known the name of this antibiotic. So there's pressure from patients and from parents, especially with sick children, to get something. You'll tell them, I'll give you something for fever. But at night, something happens at night with children. The fever comes back. So they feel that they need something stronger. So even if you tell a mother, I want to give you an antibiotic, you may not need it. They'll go somewhere else, And if they don't get it, they go somewhere else. And somewhere along this, someone will cave and give them.
Give it to them.
We've had a lot of sessions talking to healthcare workers around when to prescribe, what to prescribe, how long to prescribe. We've developed guidelines for using antibiotics so that people know what to use even when they need to use that. But I think we still have a long way to go because maybe many of the healthcare workers also self-prescribe and it's become a habit to prescribe. But that's an area that I think hospitals have to start paying very keen attention.
Yeah.
I think the other interesting thing that someone told me was that,
Go on.
Someone told me was that a lot of profits from pharmacies, whether they're in-hospital pharmacy or community pharmacies out there, a lot of the profit is from antibiotic sales. So there's also commercial interest in pushing some of these antibiotics.
I know later we'll have to talk about best practices around the world. But I'm just curious what happens when, once you develop this antimicrobial resistance, my biggest fear is whether there's a reversal of it. So once you've developed it, what happens, Daktari? Now you are antibiotic resistant. It's happened. What does that mean for the body? What does it mean for how medication works in your body or doesn't work? And then what can you do?
So the non-resistant bacteria, non-resistant virus, we actually call it wild type virus, the one that's it's not been exposed to anything, tends to be the fitter one. It multiplies better because it's in its native form. It hasn't changed, which means even if someone has some resistant bacteria in them and you don't keep taking antibiotics, over time, what we'd refer to as a wild type or the native one begins to take over. So if someone is off antibiotics, then over time you have more of the original or natural bacteria rather than this mutated bacteria that's resistant. So the issue is if someone has been taking, stop taking it if you don't need it, right? Of course, we have situations, particularly in hospitals, where people come with very severe infections and they end up on many courses of antibiotics. And many times it gets to a point where the bacteria is resistant to everything and we are struggling to find something that will work. So for someone who's not at that point, stop. If you've been doing it, it's been 3 months since I took an antibiotic, let me just take a bit, It's time to stop that so that you have, you're not.
No, but why? Is that some kind of addiction?
I don't think so. It's sort of like the last time.
What's that?
Prevention
is better than cure.
I think it's also the thing of I got a flu last time. I went to hospital. I was given this. So if I feel something coming, I left a bit of that. Let me take a bit of it now because that's practice that we see. You're given antibiotics to take for 5 days. On day 2, you feel better, so you keep the rest. Guys, don't throw it away. So next time you feel the same symptoms, you take a bit of what was left over. Or the child, this one got sick. They got better, we stopped. Now this one is sick, whatever was left over, let me give to this other one.
That one I feel attacked.
I'm sorry. So you'll end up with a bit of antibiotic taking. So the main thing is to stop taking antibiotics when we don't need it, because then we revert back to where we were.
Okay. Finishing the doses, I don't think we got. Why is it important to finish your antibiotic dose?
So this is an interesting one, maybe a little controversial. So for a long time, the evidence to inform how long someone should take an antibiotic was very weak. So people sort of ended up saying it's 7 days, it's 10 days, it's 14 days, but there was really no evidence to inform it. Over time, there's increasing evidence that we probably need shorter courses of antibiotics than we thought we did. So for a long time, someone with a pneumonia would be treated with antibiotics for 7 to 10 days. Now we know that 3 days is probably sufficient. So I think that's probably a good thing, because if you're given for 10 days and you stopped it after 3 days, probably you've done yourself a little more good than harm, because you probably did not need it for the 10 days. But having said that, it's really important to follow instructions and complete a dose of something, because again, people don't complete and they keep it. I wish they didn't complete and threw it away. They keep it and they keep taking
That's also
a little.
important to say.
For future use. Why waste in a harsh economy?
No, Eric. But what I am hearing is you don't have to do like the whole 5 days. If you're not keeping it for future use, then essentially we have been maybe overtaking antibiotics.
So, wait, at the risk of being lynched, I'll say, no, first, it's important to follow the instructions here, because if you only expose the bacteria to some dose of antibiotics, so say you've been asked to take an antibiotic 3 times a day, you take it today morning and you forget the rest of the day, then tomorrow morning you remember to take it. What happens is that the level of antibiotic is really low, so the bacteria then has even more opportunity to change, because it's just being exposed to a little dose. So take the dosing as prescribed. That's an important one.
What are the signs that antibiotics are no longer working on a patient?
So the way we know for sure, of course, if an infection is not improving. But having said that, most infections are not bacterial infections. And the commonest infections people self-prescribe for are, the homa, sore throat, or diarrhea. Someone's like, they ate someone, they have some diarrhea, they go and take antibiotics. Most of those are viral infections. They don't require antibiotics. But where we have a bacterial infection, so say one of the common bacterial infections is things like urinary tract infections, especially in women. So where they keep getting a urinary tract infection and you're treating and it just doesn't go away. So when infections become very recurrent and you have difficulty controlling them, that's a sign that there may be something going on here. We struggle with resistant infections in hospital. So someone has come in or has been in hospital, because hospitals by nature have a lot of resistant infections because there's a lot of antibiotic use within a hospital. So there you're treating someone and they're not getting better. But we use the lab, what we call microbiology, So microbiology tells us, and we do something called culture, where we take some blood or some urine and we put it in, culture media, and the bacteria will grow. And once the bacteria grows, then we can expose it to different antibiotics, and it tells us which antibiotic works and which one doesn't work. So it's important to have good lab capacity in a country.
Okay. Question. Is resistance mass? How do I... Like, the fact that some people are getting antibiotic resistance, does that mean that then the strains of bacteria are getting stronger, not just for one person, but for, is it a public health concern?
It is a public health concern. It's a big public health concern, particularly in the context of hospitals. Some of the work we do around the country is supporting microbiology labs to do good work and tell us what is growing, what do people come with, what antibiotics does it respond to. And the work we have so far suggests that some of the commonest bacteria that we have, probably 60-70% are resistant to the common antibiotics that we use. And when that begins to happen, it means in hospitals we're struggling. And struggling here means people will die, because when you can't treat a severe bacterial infection, people will die. But it also means that we have to start using what we call more broad spectrum antibiotics. And these are more expensive. They may be associated with more toxic effects to someone as they take them. And that is a concern in hospitals at the moment. We've also had situations, particularly in newborn units, because newborns are very vulnerable. They can get infections. And one of the now sort of bacteria that's becoming very common tends to cause outbreaks in newborn units. And we've had situations where you lose multiple newborn babies because of resistant bacterial infections. So yes, it is a public health concern.
A big one.
So what's been done about it?
Okay, so from many of us as researchers and teachers, we're talking about a lot more training around how to use antibiotics well. We've done a lot of work in country around informing on what bacteria we're growing and what they are susceptible or resistant to. And then, of course, we have to think about, in hospitals particularly, how do we prevent infection? So infection prevention is important, both in the community and in hospital. In the community means, let me prevent myself from getting infection so that I don't have to get treatment, Prevent an infection so you don't have to treat it. And those are very basic things. Personal hygiene, wash hands, eat clean food, avoid overcrowded places, things that keep you healthy, sort of what we did during COVID, the same things are very, very important. So that's at an individual level. There are certain things like getting vaccinations. That's why we vaccinate children, to prevent infections. So prevention is an important component. Within hospitals, infection prevention is important. A lot of these infections, we spread them because we are touching this patient and touching another patient. So we have to think about hand hygiene in hospitals. We have to think about protecting patients in hospitals. And if hospitals don't do that well, then we end up with outbreaks within the hospital.
You'll pause there, Dr. Ariankam. These are really good tips. In fact, I was going to ask what are like the 3 behaviors that you would recommend Kenyans to do to just counter misuse. Dr. Loice Ombajo is an infectious disease specialist talking about the effects of misusing antibiotics. We'll come back after the break to discuss what more can be done, some of the best practices, and just our own culture. What do we need to shift within ourselves? We'll be right back. Nice.
I feel like a fixer.
Yes,
You're
a fixer.
You have been a fixer.
Yes. Paul Miner, Staki Mapepe, says, good morning, Eric, Janet, and Mariam. Why do doctors differ on prescription? One time I had a patient at a renowned hospital, and when I moved to another, the doctor there prescribed differently. The other, I'll go through 2 more, and then we can see if we can answer that before we continue the conversation. Samson Munialo says, good morning, this is a very important topic. Oh, he's saying be displaying the name of your guest. I was reading like, oh, he's going to say something on antibiotics. Okay, so we will be displaying the name of the guest. That's good feedback. KK, a bit of a deep one here, but he says, I've been in a mental hospital and the psychiatrist prescribed drugs, and after taking them for some time, I wanted to quit, but my parents were suspicious of my healing. Can she force me to continue?
Can doctors force you to continue?
Can doctors force,
a dosage? Okay.
Yeah.
And he called, he says antibiotics for Frankenstein's monsters are called anti-harassment.
Gosh.
Is that what he means?
Yeah, I know I'm trying to decode as well.
Yeah. I'm guessing he means the version of something similar to antibiotics for psychiatric. Yeah, they're called anti-harassment.
Okay.
I don't know, but Doc will answer.
Yeah. So the one for differing on prescription.
Yes.
Yeah.
Well, that's an interesting question. So we have doctors who are in different specialties at different levels of training, different cadres. So in Kenya, healthcare will be provided by nurses, by clinical officers, medical officers, and you have consultants who specialize in different areas. And yes, people may differ in opinion because that's human. People may differ because of knowledge and evidence that they have. But I think the best practice is always to use evidence-based practice as opposed to just opinion, so that even for myself as a consultant, I won't just stick to my opinion. We are constantly doing research to generate data that informs the work that we do. So sometimes where there's such differing opinion, it's best to try and see a specialist because they'll probably be having more evidence in that area of practice than someone who's not specialized in a certain area.
One would expect that this becomes a cyclical pool of information where, yes, the younger physician who doesn't have much experience dealing with these kind of conditions would be relying on something. on knowledge, but also on their seniors.
Yes.
That's why you do an entire internship for a whole year working under a senior. But I want to go back into research. Research by a pharmaceutical manufacturer and research labs will develop this antimicrobial, right? They'll go through several tests. Clinical trials will come in, and then they will be given approval for this to be used.
Yes.
Should those medicines, or do those medicines actually have the recommended dosage based on research that showed that for this, for instance, this particular drug that we have produced, if you just give X amount within X number of days, you should be okay. So then you don't have this 3 to 5 days, 7 to 18 days.
Yes.
Maybe the first point is, hii ilitengenezwa ya siku ngapi?
That's true, and many drugs come with the doses prescribed already. As I said earlier, for a long time we really did not have evidence for duration of antibiotic use, and there's almost this 7 days, 14 days, 21 days, so multiples of 7 is what we sort of used. But increasingly we have evidence now emerging. I think there's a very good paper recently that looked at a very severe infection, what we call bloodstream infection, where someone has bacteria in the blood. It's a severe infection, and for a long time we've treated it for 14 days. But now recently we have this paper that says there's no worse outcome if you treat it for 7 days versus 14 days. And that's good for us because it means you then reduce the amount of antibiotics someone is exposed to. So as evidence, again, duration was always a tricky bit, and it was sort of guesswork. People just threw in something and it became practice. But over time, we're getting more and more evidence. I mentioned, for example, pneumonia would be treated for 7 to 10 days, but now we know that we treat pneumonia for 3 to 5 days. So evidence evolves, and we have to evolve with it.
So, Dr. does that research then come back into forming the standard?
Yes.
At the clinical stages?
Yes.
Where, yes, there's research, there's paper, then there's peer review, and then it comes and becomes, this is the new standard. So, a doctor does not have to say, no, me, I did not see that research. It's
So
basically
that-
brought
yeah,
to them
yeah.
that this is, from this point on, pneumonia treatment start a dose at 3 days, standard, and only extend if you.
Yes. So that's why we draw guidelines. And for example, for antibiotic use, we have developed the National Antibiotic Use Guidelines that gives the issues of how do you make a diagnosis that, you know, you're pretty sure this is pneumonia. What antibiotics do you use, and what's the appropriate duration of antibiotic use? And we disseminate these guidelines throughout the country. So
As
hopefully,
Ministry of Health?
Ministry of Health does. A lot of this we develop to support the Ministry of Health, and all these have been disseminated around the country.
I'm asking that because is it enforceable? You know, it can be disseminated,
But not enforced.
but not enforced,
Yes.
or even disseminated but not a requirement, not mandated.
That's an important point. Many times what someone does on their own is not necessarily enforceable, but hospitals also have what we call the medical advisory committees that one, disseminate guidelines within a hospital, but also serve as peer review for what people are doing. So the aim is that all hospitals have strong medical advisory committees that can review the practice of doctors working there and help to guide people towards doing what is right. A lot of continuing medical education sessions are held as well, and everybody who wants to have the knowledge can join those. But of course, we're humans, so we can't force everybody to do what they should
What you're
do.
supposed
Toe
to
the
do.
line.
Yeah, you'd asked a question about TB,
Yes.
HIV. Yeah.
Yeah.
That those are also getting antimicrobial resistance.
Yes.
What does that look like? Are the causes the same, more or less, or is it something different? How big of a concern is also now resistance to
Yeah.
TB medication and HIV medication?
So the reason bacteria are concerned is what I mentioned earlier. You have normal, healthy bacteria as part of what we call normal flora. They exist in your body. But people don't have normal, healthy TB or normal, healthy HIV. You know, those are all foreign. So those then require different treatment. So for TB, for example, the treatment duration is actually 6 months. But over time, there have been increasing TB that's resistant to the normal anti-TB drugs that we use. And there's been a lot of effort to develop new anti-TB medication. With resistance, the question is always increased mortality. The risk of dying from an infection when whatever is causing it is resistant is much higher than if it wasn't resistant. Yeah. And TB, for example, drug-resistant TB is associated with high mortality. When we come to HIV, again, HIV is lifelong treatment. And over the years, we've had to change sort of the standard HIV treatment because some drugs were now, the virus was now resistant to some drugs. So the treatment has been evolving based on whether the drugs work or not. So currently, the standard regimen, which almost everyone who's being treated for HIV is on, is a pretty good drug. But even with that, one of our biggest studies currently is actually looking at resistance to that HIV treatment. The problem with HIV and TB, and this ties back to, these are not normal things that would occur in the body, is that resistance develops when you don't take the drug as you should. So if someone has HIV, for example, you're asked to take a pill every single day. If someone takes a pill today, gets tired for 2 days, takes another one, then the virus also now is smart and it begins to change its characteristics so that by the time you're now taking it, it's not working. And the same with TB. If someone takes it this month, they take it, it's many pills, it's tiring to take. The next month, they don't take it. And the bacteria that causes TB also changes.
Right.
Yeah. So that's the difference with bacteria and HIV and TB.
Is it dystopian? 5 years ago, I watched a short film that really changed my habits on. It just came, and it showed an antibiotic-resistant world. It was one of these, films that almost imagine, but it frightened me because it was just showing this father who has to wear a mask and hazmat around the daughter, and they're coloring. And one day she wakes up and she's coughing, and he's like, Kwisha.
Oh, no.
So she's, and they kind of had a message there about use of antibiotic. Could there be such a time that there's worry globally, or do you think medicine will keep evolving, or is there a part of you that's saying if we don't get ahead of this, globally this is how it can affect people?
So yes, we could get to that point. WHO has says that antibiotic resistance is probably one of the 10 threats to global health at this point. The thing about antibiotics is it's not easy to develop a new antibiotic. And there's more money in drugs for blood pressure and diabetes and the rest. So companies are running to develop those, but we don't have too many companies developing new antibiotics. And if we look at the landscape of new antibiotics over the last several years, you'll find that there are probably just 3 or 4 new ones. And there aren't too many new ones in the foreseeable future. So it's not as if we can afford to just destroy the ones we have and hope new things will keep coming. So we must really take care of what we have now, because we see that world, and I guess because of my work, I get a lot of consultation because of difficult to treat infections. And I see a glimpse of that where someone has an infection and I have absolutely nothing that would work for them. So that's a really bad place, and we have situations like those.
And it leads to death.
Frightening.
It leads to death.
Yes.
From this document, I'm seeing the WHO is saying that antimicrobial resistance is actually a global health priority, one of the leading public health threats of this century. According to data, 1.3 million deaths globally are attributed to antimicrobial resistance, with Africa having the highest percentage. 24 deaths out of 100,000 are attributed to antimicrobial resistance. So that's where you get to that point where somebody has come to you and no medicine
There's nothing
would help them.
Yeah.
So it just basically leads to their death.
Frightening reality. Best practices, what do you see happening that we could adopt here?
So it's actually possible to turn the tide, and a lot of it is around infection prevention and control. We have to prevent infections. The more infections we have to treat, the more resistance we'll have. So we really have to think about how do you stop yourself from getting sick so you don't need antibiotics. That's one for anyone out there. In hospitals, where hospitals are like the hotbed of antibiotic resistance, it's how if someone comes in and they have a resistant infection, how do you prevent it from spreading to other patients? Because there are people who go into hospital you've gone in with your broken bone, but you need to be in hospital for a few days, you need surgery, but you end up with an infection that can't be treated. And what kills you is not what took you into hospital. So within hospitals, we have to think about how do we really prevent infections. Then, of course, we have to think about reducing antibiotic use to only when it is necessary, so we have less resistant bacteria emerging.
Yeah.
From a research perspective, what are we doing research-wise as a country? From institutions, actually, like the University of Nairobi, and onwards, or even all the way to KEMRI. I think we lead the way in a lot of things. I don't know if we're doing the same with antimicrobial research.
Yes. So I think a lot of the work that we've been doing recently has been around what is the status of our nation? Where are we? Because we cannot respond to something we don't know. So we've done a lot of surveillance work around antimicrobial resistance, and that's why we're able to say that in hospitals now, most of the bacteria that cause the common infections are resistant to the antibiotics we're using. But we also know that in hospitals, for example, almost 50% of people in a hospital are on antibiotics. We always joke that if you trip and fall into a hospital, you will be on an antibiotic.
Man.
So we really have to think from a hospital level, how do we reduce that? Then the types of antibiotics we use. There are certain types of antibiotics that are more likely to cause this selection of resistant bacteria. And unfortunately, in hospitals, we use those antibiotics a lot. So even just rethinking our choices of antibiotics is an important component.
Right.
Of course, then it also says, can we bring in new antibiotics into the country? So there are a few, I said, over the last few years, there have been a few new antibiotics that have been developed. If you think about the public health sector, none of those are available. In private hospitals, I remember a few years ago treating a patient who needed a specific antibiotic. Luckily, they were very wealthy, and they got relatives in Germany who flew in this drug for them to use it. So imagine yourself lying in a public hospital and you need this drug. It's not going to come. Not even in a public hospital. Majority of us, with even in a private hospital, may not afford those. But some of the work that will be drug to you. So some of the work that's going on is also seeing how we can begin to access some of these new antibiotics so that if we get to the point where someone needs it, then it's available to them.
Oh, there's an interesting point here. Mama J saying antibacterial soaps contribute to antibacterial resistance. I wonder why government doesn't ban them. Is that accurate?
So I don't know if they're antibacterial soaps. They're antiseptic soaps. So I think maybe she's referring to things like Dettol and the rest. I'm not sure that they contribute directly to antibiotic resistance. They're probably not very necessary. We all throw on things and take on things that may not be very necessary when all you need is just basic soap and water.
Are there resistance?
Sanitization, sort of.
Oh, right.
Like
overdoing it.
Yeah.
I know, sanitize your hands.
No. I didn't mean
Overdoing
over-sanitization like that. I
Don't
mean
use
like
soap too much.
No, take a shower every day.
Don't use harsh.
My mom is like, wait, let me say.
Let me
Explain.
explain. I feel like
Hear me out.
we do sometimes hygiene Olympics, which is how shiny and squeaky, and then that's when you end up using now stronger things like antiseptic. In bath water, things like that. I don't know. I'm just thinking out loud here. I feel like on my skin, whatever good things are happening there, if I expose them to antiseptic, I don't know if that's going to be. This is just me thinking out loud.
Necessarily of benefit.
It's that's interesting. I remember there was a big conversation on a couple, a well-known couple abroad, who said we only bathe our children twice a week, and the internet was just some people said healthy germs on your skin. Others were like, hey,
don't strip off all the oil.
That's actually what they were saying. But you would say to such people, what, Dr.
I think it's important to keep clean. I don't know if there's an ideal number of times to shower, but if you don't shower, especially in this hot environment of ours, you'll smell and make people around you uncomfortable.
Let's go back to basics.
You just tell them, but the bacteria on my skin is good.
The bacteria on your skin will be suffocating under your sweat. So.
Fair enough. It's good to say that.
But I like that. So no need for like antiseptic soap. Like regular soap and water?
Yeah, for most people, antiseptic soap is not necessary. Just regular soap is fine. I know, especially mothers, they think, oh, my child's skin has a lot of germs and I want to get rid of these germs. And I guess there's no major harm to it, but it's not as if you have to use an antiseptic soap.
I use antiseptic soap on my hands and on my children's. I've been a believer for 10 years. And I'm like,
Beyond the
because it says 99.9%
all bacteria.
Yes, and it makes me feel safer. And it's promoted for hand washing with soap.
Exactly.
Exactly.
Which brings me to my next question: how to do safe germ exposure for children and even for adults, honestly, because I do think there's tunaogopa uchafu sana.
Germs too much.
Then
Okay, that's a very interesting point. I'm not sure there's a safe level of exposure, but I think allowing children to be children, allow them to play. Unfortunately, in that case, they'll eat some things that they don't eat. But I guess the understanding is that with exposure to certain things, you also develop some immunity to the same things. So you don't have to keep someone in a sterile environment because then the minute they're exposed to something, they're not prepared for that. But allow children to be children, allow them to play, allow them to enjoy, and teach them to wash their hands, teach them to not put dirt in their mouth, you know, teach them just the basics of hygiene.
Are there resistance hotspots in the country?
oh wow.
So with the surveillance work, and this is data that's sent to the National Public Health Lab from about 20 labs across the country. Unfortunately, the labs that have capacity to do this good microbiology work are not that many, and that's really, I think, a call to government to step up in that area. So the 20 labs we always like to joke that they're sort of along the railway line. You know, all the towns that are along the railway line. We have very little data from the northern and eastern parts of the country, and not too much from the southern tip of the country. So the data from that shows that resistance is actually fairly widespread across the country. You can imagine that in cities with more people, bigger hospitals, more pharmacies, there may be a little more resistance, but we've seen quite an even spread of resistance across the country. And maybe that's because there's a lot of movement. You know, people sort of don't just sit in one place. There's a lot of movement, and there's a lot of pharmacies. If you go into any center in this country, you'll find one or two pharmacies, and there's a lot of community antibiotic use, and that may explain why it's sort of standard across the country. We thought it would be most in the referral hospitals alone, but we're seeing it even in the county hospitals as well.
Okay.
I'm looking at this research that you've done at the University of Nairobi with the Center for Epidemiological Modeling and Analysis. It says that there was high resistance observed in E. coli, pneumonia, and S. aureus. What's S. aureus?
So those are the three bacteria that commonly cause infections, as we see in hospitals. So E. coli, the other one is called Klebsiella, and another is called Staphylococcus. So those are sort of the common causes of infections that we see in hospitals.
Okay. Now, it goes on into looking at the effect of that, but then the policy recommendations, one, the Ministry of Health to undertake initiatives to improve public awareness on the dangers of self-medication with antibiotics. The Pharmacy and Poisons Board to enforce regulation on over-the-counter antibiotic purchase as per the law. Sustain the capacity of the microbiology labs for detection and surveillance. Now ensure that antibiotic quantification and procurement by KEMSA aligns with the microbial surveillance data and national antibiotic use guidelines, adherence to guidelines, supporting adherence in Kenya, and for government to earmark funding for antimicrobial resistance surveillance containment. All this sounds like it's work that government should do, and the profession of medicine in Kenya should do. Okay? If you did your job, we'd be safe, basically.
That's true. If we all did our jobs better, and this starts from government. I'm not getting government out of it. Because there are certain things that government must do, because they are the ones that have the capacity to do it. You know, if it comes to restriction of use, that has to be enforced, and it's the Poisons and Pharmacy Board, Ministry of Health, that should enforce. When it comes to building capacity of hospitals, so that it doesn't matter whether you're going to a private hospital or a public hospital, you should be assured that you'll get the best care, and that there's capacity to find out what's wrong with you. That's something that must be done at that level. when it comes to hospitals aligning with guidelines and using guidelines, you asked the question earlier of why do people practice different things. So if we all did that better, everyone would be safer. But I think there's, I forget which minister this was, who told us your safety starts with you.
Was it
the president?
Who was it? Someone told us your safety starts with you.
It was the president.
Okay.
Your
I think
security begins with you.
Begins with you.
Yes.
And here I'm going to say your health begins with you. You know, you can't, I remember when I was learning driving, someone told me, assume everyone on the road is a drunk driver. When it comes to your health, assume everybody else, you know more about your own health than everybody else, and take care of yourself first. Prevent infections so that we don't have to treat them as much as possible. Some will come in spite of our best efforts, but most common infections can be prevented.
Okay.
I agree. If there's, and that's where the public awareness comes in.
Yeah.
Just showing, instilling that message of prevention, but government comes in to support the prevention efforts. And then the people who are driving the government to do that are medics.
Yes.
The people in the Pharmacy and Poisons Board who are looking at the pharmacological issues are medics. The people who are coming up with these policies and guidelines are medics. The people who will tell KEMSA this is what we need in this country at this time are medics.
Yeah.
So the medics profession, all of you together, from pharmacists to doctors, general physicians and all, if you work together and make sure that you are thinking, all of us are thinking the health of the nation, then when you come to us, but they will believe you.
Yeah.
When doctors tell us, do this, we do it.
That's fair.
Until a different doctor tells you something, we start doubting doctors.
We listened during COVID.
Yes.
We have to wrap up completely, but I just wanted to know global best practice. Is there any country in the world that you could use as a case study that was starting to see antimicrobial resistance and they've managed to reverse it?
Control it. So I think one of the best examples I may give, let's say, for example, the US. One of the bacteria we mentioned there was what we call Staphylococcus. They had a lot of drug-resistant Staphylococcus a few years back.
That's pneumonia.
It causes skin infections, bone infections, joint infections, but commonly skin infections and infections in the blood as well. But because of doing a lot of work on infection prevention, they've actually begun to turn the tide on that resistance. Unfortunately, we seem to catch up with people 10 years after they've moved on. And now we've caught up and passing where they were at their very worst. So we have to do something to turn the tide. These are countries that would have the access to all the new antibiotics. They weren't, but they also realize that they have to turn the tide because we can't keep up with the bacteria at the rate at which we have new antibiotics. Yeah. So, and if you look at, again, let's say many Western countries, you can't just walk into a pharmacy and buy an antibiotic. You have to have a prescription. I remember once going to a pharmacy and saying, "Oh, I'm an infectious disease specialist," and they couldn't sell me an antibiotic. I had to go and get a prescription, and that's where we need to get to.
Even as a daktari.
Even as a daktari. Kabisa, thank you so much. Dr. Loice Ombajo, the effects of misusing antibiotics. She's an infectious disease specialist. Thank you for sharing that information. Mama Jaya said, I've learned a lot. So thank you. Up next, by-elections. First test for the new commission. We'll be speaking to Anderitu, a commissioner with IEBC, who'll give us all those details. It's coming up to 8 a.m. We'll be back in just a moment.